Okay, so this is Rosemary Teamy, and we're going to continue on. We talked about esophageal and stomach and duodenal. So now we're going to kind of move on down the road, so they say. And we're going to cover inflammatory bowel disease. Inflammatory bowel disease has two chronic inflammatory disorders, Crohn's disease and ulcerative colitis. Both are characterized by exacerbation and remission. Both of them, it's chronic, recurrent, affects younger people. Treatment is symptomatic. Responses are unpredictable. Frequently, our clients are going to require surgery, and then they still may have a recurrence with this. When we look at Crohn's and ulcerative colitis, Crohn's is the disease of the small intestine and colon, where ulcerative colitis is the colon. Crohn's is a full thickness of the intestinal wall, where ulcerative colitis is the mucosal layer, and it doesn't go all the way through. Crohn's, we see a cobblestone effect, and we also have fistulas with that. So here you can see Crohn's disease. This is a picture of it taken from a colonoscopy. So it's full thickness inflammation. It can start in the terminal ileum. It can do the small intestine and the proximal large intestine. It can affect anywhere from the mouth to the anus. The causes, nobody knows. Whether it's infectious or genetic or immune. What we see is this cobblestone effect, and we have a thickening of the bowel wall. So we're going to have a narrowing of the bowel lumen. When we have a narrowing of the bowel lumen and we have that inflammation and we develop fibrosis, we're going to develop strictures. In advanced diseases, the bowel mucosa will have granulomas, and they have deep ulcerations. With this, we're going to see abdominal pain. We're going to see diarrhea. And this is not just what most patients will tell you, just a little bit of diarrhea. This is 20 to 30 bowel movements a day. They can have malabsorption, fistulas, bloody stools. They can develop bowel obstructions as a result of this. 20 to 30% will develop some type of intestinal obstruction. The edema and fibrosis is going to cause a narrowing. We're going to see these patients have an increase in bowel cancer, in colon cancer and small bowel cancer. Our diagnostic tests, we're going to do hemoglobin and hematocrit. We're looking for bleeding. When we say bloody stools, this isn't just a little blood-stained mucus. This is blood. We're going to see an elevated white blood cell count. We're going to have, we want to look at folic acid and B12 because of the malabsorption. We're going to look at the erythrocyte sedimentation rate. This measures chronic infection. A barium enema and an upper GI, this is going to show us where the Crohn's is. And you really don't want to do this on a patient. You really don't want to do a barium enema or an upper GI if the patient is having an acute exacerbation of the disease. And we can do a colonoscopy. Ulcerative colitis, like I said, this is just the mucosa of the colon and the rectum. It is a chronic inflammatory disorder. We don't see those nodules like we did when we saw ulcerative colitis. It occurs more frequently in families, suggesting a genetic component. We have anti-colon antibodies, so it can be autoimmune also. Stress and psychological factors can affect the severity of the illness. There's no evidence to support that stress and psychological factors can cause ulcerative colitis. Dietary factors, they say fiber-poor foods, and of course smoking. When we look at ulcerative colitis, we're going to see diarrhea again. Again, this is bloody, mucousy, purulent stool where it's not really a stool per se. In mild cases, they may have 4 stools a day. In severe cases, they can have 10 to 12. Ulcerative colitis predisposes our patient to colorectal cancer, and colorectal cancer can appear in 5 to 8 years after the onset of ulcerative colitis. The risk of cancer is 30%, increases 30% at 35 years after diagnosis. You can see, again, this is a lot of diarrhea. This is bloody diarrhea. This is mucus diarrhea. This is purulent diarrhea. We're going to see some anemia because, again, we have bleeding. We're going to see some hypovolemia just by the very fact that they're having lots of diarrhea. We're going to have nutritional impairment, again, looking because of the malabsorption. We're going to have cramping, fatigue, anorexia, and weakness. The next one I want to talk about is diverticula. Diverticula are little pouch-like herniations of the mucosa of the colon. Diverticulosis is the presence of those herniations, and diverticulitis is inflammation of those diverticula. When we look at diverticula, these are actually the little diverticula. They're just little outpouchings. And what happens is we can have an inflammation of that diverticula because we have all this stool that goes in and it gets trapped in there, and then the diverticula become very inflamed, and we see this typically in the sigmoid colon. The problem is when we get undigested food or bacteria, we can have rupture of those diverticulum. So we're going to see if we rupture it, of course, we're going to have a peritonitis, so that board-like abdomen again. We can have bleeding. It can be from localized inflammation or a hemorrhage from the blood vessel that goes underneath that mucosa. We can also develop fistulas with this, and here you can see the patient has a fistula going from the colon to the bladder. Now, if you think about it, the bladder is a sterile organ, and we have the little ureters that go up into the kidneys. So when we develop these fistulas, our patients, first of all, are going to have foul-smelling stool smell, urine. And then those little bacteria that we love because they're in our colon are now in our bladder, and they can actually crawl up there, get into the kidneys, and from the kidneys it's just a capillary membrane away from getting to our bloodstream. So with the diverticulum, we're going to be, again, assessing our patients for fistulas, and we're going to be assessing them for any ruptured diverticulum. Okay, next one is colorectal cancer. And one of the things about I'm going to say about colorectal cancer is over the age of 55, need to have your colonoscopy done. Actually, it's over 50. This is a patient that had started as a little polyp, and they obviously didn't have it treated. And now look at the lumen of the bowel. 2/3 of it is taken up by a colon cancer. And if we think about it, this cancer here can break off. It can get into our bloodstream, and we see we have a little bit of blood here. So it can get into the bloodstream, and it can spread throughout the body. I have a friend that she had, her daughter had ulcerative colitis. She wound up with an obstruction. They wound up doing surgery. She had stage 3 colon cancer and wound up with a peritonitis on top of that. When we have patients that have colon cancer or any type of surgery that where part of the colon is removed and we can't put it together, if you look at it this way, I mean, look at this. If we had a rectal cancer, we would have to have that part of the bowel removed, and so our patient is going to wind up with some type of ostomy. When we look at ostomies, we want to know where it is. So is it a sigmoid? Is it a descending? Is it a transverse? It's an ascending. Is it an ileostomy? Is this going to be a temporary or is this going to be permanent? Some patients, they can do a temporary colostomy, and that's what this is. This is a lupostomy, where they actually they cut the part of the colon, and then they form the stoma with it, and it's to let this distal portion of the bowel rest, and so the stool's going to come out through here, and this is letting the rest of the bowel rest. And this happens sometimes for patients that have ruptured diverticulum. We just let their gut rest, we let that colon rest, and then in about 6 to 8 weeks they can go back in and have it fixed. Some of the complications with ostomies, first of all, is we can have pallor. This is a normal ostomy. We can have pallor here. And pallor means that we're not getting a blood supply. So somehow during the surgery, all of a sudden, we now have part of the colon that is not getting any blood. When we have this, we can also have gangrene, and that's what happened here. We have a nice little gangrenous ostomy. So we had blood supply that was not restored, and so now we have a gangrenous stoma. We can have prolapse. This is the colon is actually prolapsing from the suture site or the stoma site. So this is part of the bowel, and we know that we don't that this is, first of all, one problem with this is it's going to be hard to fit a stoma on top or fit a ostomy on top of that. The other part is too, with a prolapse, we can have strangulation of the colon, and now we've got this part of the colon that's out, and it should be nice and moist, and now we have all of this colon that is going to be strangulated in there. We can also have a herniation, and that's what this is. This is actually the bowel is underneath, coming through the muscularis, and which is why we see this big bulging here. When we monitor the stoma, we want to keep monitoring it. We start as soon as they come back from surgery. We put a bag on it. We check that bag. We always check to see what color is the stoma. Oh, and this last one here, even though it is a beautiful stoma, look at the maceration around it. This is because of an ill-fitting stoma colostomy bag. And that's about it. Let me see what else we have. Any questions, please email me, and I will see you in class. Thanks, and have a great day.